very vascular and can bleed liters of blood. The signs you want to look out for are hemodynamic instability on vitals or peritoneal signs on abdominal exam, which reflect fluid in the abdomen. If you see any of these signs, get in touch with the OR. They've got a case coming in. Now moving on to some slightly less hair-raising scenarios. In the following cases, the patient will be stable and the goal will be to assess whether she has an ectopic pregnancy or intrauterine pregnancy. Okay, so you've got a positive beta HCG and you're doing a transvaginal ultrasound, but you see nothing. You scan around to try and see if there's any evidence of an extrauterine pregnancy, but still nothing. What you've got on your hands here is a pregnancy of unknown location, often abbreviated as PUL, just like on the button this guy's wearing. It's exactly what it sounds like. You know your patient is pregnant from the positive beta HCG, represented by this guy's beta sunglasses, but you don't know where it is, represented by this broken ultrasound bullhorn. The first thing you're going to want to do if you find yourself in this situation is to assess whether or not you should be seeing an intrauterine pregnancy. You can figure this out by noting whether or not your beta HCG value is above or below the discriminatory zone. Remember the discriminatory zone? It's the value above which you should be able to visualize a pregnancy on ultrasound. Let's start with a scenario where your beta HCG value is below the discriminatory zone. So you know that your patient is pregnant, but she's so early in her pregnancy that you shouldn't see a pregnancy yet on ultrasound. But she's complaining of abdominal pain and some vaginal spotting. This is when it's really important to have a conversation with your patient. Is this a desired pregnancy that, if normal, she would like to continue? If it's the beginning of an early pregnancy loss, what management routes is she open to? Does she need more time to think about it? Probably definitely this last one. It's a lot of information to take in. Also, since this pregnancy could still be an ectopic pregnancy, you must counsel her on the possibility of this as well as the possibility of rupture. Let's look at the scenario where she does desire this pregnancy and the beta HCG is below the discriminatory zone. Because this patient is stable, it's okay to wait to see if the pregnancy is developing normally and wait to see whether or not you can visualize an intrauterine pregnancy once her beta HCG is above the discriminatory zone. You'll do this by getting serial beta HCGs. This means you'll draw a new value every 48 hours until you have a definitive diagnosis. The beta HCG should roughly double every 48 hours up until around 10 weeks gestational age. In addition to looking for a normal rise in beta HCG, when the HCG value is above the discriminatory zone, you should check to see if you can visualize an intrauterine pregnancy on ultrasound. If the HCG value does double every 48 hours over a few checks, and then an intrauterine pregnancy is visualized once the HCG is above the discriminatory zone, then she most likely has a normal pregnancy and can continue on with standard prenatal care. If you start trending beta HCGs and they do not double every 48 hours, then you have some sort of abnormal pregnancy on your hands. Either an ectopic pregnancy or a pregnancy that will likely spontaneously abort because it isn't developing normally. If you have an abnormally rising beta HCG level, represented by this shorter stack of beta sunglasses, plus you see an adnexal mass on ultrasound, represented by this black Tamagotchi, you can assume that this is an ectopic and treat accordingly. More on that in a bit. If your beta HCG is abnormally rising and there is no adnexal mass, represented by this shorter stack of beta sunglasses with no Tamagotchi on top, you have a few options to discuss with your patient. Basically, you can either treat this as a non-viable pregnancy that will likely result in pregnancy loss, or you can treat it as an ectopic. The first option is to perform suction curettage, also known as dilation and curettage, or a DNC, which is why there's a curette mirror on top of this beta sunglasses rack. This option is both diagnostic and therapeutic. If the fetus is abnormally developing this early in the pregnancy, it's almost certain that it will result in a pregnancy loss, and performing a DNC will both evacuate the abnormal pregnancy and tell you definitively that the pregnancy was intrauterine and not an ectopic by checking for chorionic villi in the uterine aspirate. If there are chorionic villi, you can be sure that the pregnancy was intrauterine and not an ectopic. If that patient doesn't want to undergo a surgical procedure, another option is to treat this pregnancy as an unruptured small ectopic pregnancy. In this case, you can presumptively treat with methotrexate, represented with our recurring symbol, meat sticks. We'll go over this medical treatment for ectopic pregnancy in more depth in just a bit. Speaking of treatment, there are three broad categories: expectant management, medical management, and surgical management. Expectant management is letting the pregnancy run its course until it involutes. Because of the potential of ectopics to rupture, the risk of choosing this management path should be discussed in detail with the patient. For the same reason, the criteria for expectant management is fairly stringent. There should be no evidence of an extrauterine pregnancy on ultrasound, and the beta HCG should be less than 200 milli-international units per milliliter and decreasing. The other absolute requirement for expectant management is that the patient must have reliable follow-up. This means that they have a working phone number, stable transportation, and are willing to follow all instructions when it comes to returning to the lab to get their beta HCG trended down to 0. If while trending the patient's beta HCG you find that it's rising, you must move on to either medical or surgical management. For medical management, the folate antagonist, methotrexate, again represented by the meat sticks, is used. It inhibits DNA synthesis and will terminate the ectopic pregnancy. When choosing methotrexate, it's important to make sure the patient meets all of the eligibility criteria. These criteria are that the patient is hemodynamically stable and that they have a beta HCG less than or equal to 5,000 milli-international units per milliliter. There should also be no fetal heartbeat seen on ultrasound, and she has to have reliable follow-up. Some providers will use a size cutoff as a part of their inclusion criteria. This is not an absolute requirement, but know that the cutoff is usually 3.5 centimeters. As in, if the ectopic is less than 3.5 centimeters, the patient is eligible for methotrexate. The reason for all of these criteria is that if they're not met, studies have shown that the likelihood of treatment failure is higher. In addition to meeting the inclusion criteria, patients must also not have any medical contraindications to methotrexate. These are a ruptured ectopic pregnancy, evidence of renal or liver disease on labs, chronic lung disease, immunodeficiency, or actively breastfeeding. To ensure that the ectopic pregnancy has responded to methotrexate, serial beta HCG should be drawn until the value is 0. This usually happens between 2 and 4 weeks after methotrexate administration. If the patient does not meet the criteria for methotrexate treatment, this is when surgery should be considered. The main indication for surgical management is a suspected ruptured ectopic. We've made these scalpels unstable so that you're reminded that if your patient has unstable vital signs or signs of an acute abdomen, they should get emergency surgery. The other indication for surgical management is if the patient has failed methotrexate treatment, which is why we've put these scalpels next to this old failed meat stick. The two types of surgery you'll do to assess what's going on in the patient's abdomen are either an exploratory laparotomy, also known as an XLAP, or exploratory laparoscopy. The decision whether to perform open versus minimally invasive surgery depends on multiple factors, such as surgeon preference and patient body habitus. Once you're inside the abdomen and have visualized the ectopic pregnancy, there are two options. Either cut the fallopian tube and the ectopic out, called a salpingectomy, or just remove the ectopic pregnancy through making an opening in the tube, called a salpingostomy. If the ectopic is ruptured, you must perform a salpingectomy. A quick but very important note. When removing the fallopian tube, you should not remove the ovary. The ovary provides the oh-so-important estrogen for continued cardiac and bone health. It also contains your patient's eggs. If you remove the ovary, you'll compromise both overall health and future fertility. As with any time the maternal-fetal barrier is potentially breached, all Rh-negative women should receive anti-D immunoglobulin, also called RhoGAM, within 72 hours of the inciting event. The main complication of both medical and surgical management is treatment failure. This means there's residual chorionic and embryonal tissue, usually reflected by a beta HCG value that does not resolve to 0, or worse, begins to rise again. The options if either of these happen are to give another round of methotrexate or to proceed with surgical management, if that was not the initial form of treatment. Okay, so we learned a lot while reliving our past punk phase over here at Ectopic. Speaking of ectopic, today we learned about ectopic pregnancies, which are non-viable extrauterine pregnancies that most commonly implant in the fallopian tube, specifically the ampulla. The most common chief complaints are first trimester vaginal bleeding and lower abdominal pain and pelvic pain that happens around 8 weeks after the patient's LMP. Those at the highest risk of having an ectopic pregnancy are those with a history of an ectopic, PID, scarred tubes, and those who have had IVF or have gotten pregnant with an IUD in place. Ruptured ectopics are the most concerning complication, as they can lead to massive hemorrhage and even death if left untreated. You should be concerned for a ruptured ectopic if your patient is hemodynamically unstable and/or she has any peritoneal signs on abdominal exam. In terms of an assessment, the two most important studies to get are a beta-HCG level and a transvaginal ultrasound. You'll be concerned for an ectopic pregnancy if you have a positive beta-HCG level but no intrauterine pregnancy seen on transvaginal ultrasound. If the transvaginal ultrasound shows a pregnancy outside of the uterus, then this is a definitive diagnosis of an ectopic pregnancy. If you have a positive beta-HCG level and can't see a pregnancy anywhere in the abdomen, this is called the pregnancy of unknown location, or PUL. If you have a PUL, the first thing to note is whether or not your beta-HCG level is above or below the discriminatory zone, which is usually set around 2,000 milli-international units per milliliter. If the beta-HCG level is below the discriminatory zone and the patient is stable, you'll want to trend it every 48 hours for two reasons: to see if it's rising appropriately and to see if you can visualize an IUP once it's above the discriminatory zone. If your beta-HCG trend is showing an abnormal rise plus a complex adnexal mass on ultrasound, you most likely have an ectopic, so you'll treat it as such. If your beta-HCG trend is showing an abnormal rise but no complex adnexal mass on ultrasound, you can do a diagnostic and therapeutic D&C or treat with methotrexate if appropriate. The idea here is that this pregnancy is abnormal in some way and is either intrauterine and needs to be removed, or is an ectopic, which should resolve with methotrexate. When you've decided, hey, I think my patient has an ectopic pregnancy, you have three treatment options: expectant, medical, or surgical management. Expectant management has very stringent criteria, such as no masses on ultrasound, a very low beta-HCG of less than 200 that's declining, and good follow-up. Methotrexate is used if the patient is stable, has an HCG less than 5,000, no fetal